And today I will be talking about gastroesophageal reflux disease, also known as GERD. So there are a few phrases that are used interchangeably but actually have very different meanings and definitions. So GERD refers to the disease with regular symptoms caused by the flow of gastric contents or a retrograde of stomach acid into the esophagus. Heartburn is a symptom of GERD, and acid reflux is actually the reason why patients have GERD. The prevalence of GERD is extremely costly. It's a significant economic burden through indirect and direct costs, thinking about medications, provider visits, etc., upper endoscopies as well, diagnostic testing. 25 to 35% of adults in the United States have GERD, and given that significant economic influence as well, even just a few years ago, the healthcare expenditures were already exceeding $12 billion in the United States. And as we talk about risk factors for GERD and the demographics of the United States, such as including a greater percentage of obesity, we're absolutely going to see that $12 billion, that number is going to skyrocket. So GERD can really be broken down into a few different mechanisms as far as our pathophysiology. The big one being a decrease in tone of the lower esophageal sphincter, or we'll just call it the LES for the rest of the presentation. With a decrease in that sphinctal tone, we are placing the esophagus at risk for gastric contents that really, due to a difference in pressure, so our LES should maintain a pretty high pressure in relation to intragastric pressures to prevent backflow. And as we are eating and drinking, there is this transitory relaxation of the LES that occurs. This is not something we can control. We're talking about smooth muscle here. So with that transitory relaxation, that is allowing the passage of food into the stomach, where we can begin the stomach can begin its digestive breakdown and process. But when the intragastric pressures are exceeding the pressures of the lower esophagus, we're going to see that backflow and that failure of one of the protective mechanisms that usually prevents us from having, acidic content, such as gastric contents in our esophagus. So there's a pressure mismatch and kind of dysfunction that is happening first. And there can also be the presence of a hiatal hernia. When we think of a hernia, we tend to think it's different than the few that first come to mind, like a inguinal hernia or abdominal hernias, indirect versus direct. A hiatal hernia, we are seeing a condition in which the fundus, the upper part of the stomach, is bulging through the opening of the diaphragm. And basically a portion of the stomach is now in the chest cavity. It's sliding into a portion of the anatomy. It's not where it should be. And not everyone who has a hiatal hernia can have symptoms of reflux. A hiatal hernia can exist independent of reflux symptomology, but regardless, the presence of a hiatal hernia plays a significant role in talking about the dysfunction of the lower esophagus, talking about anatomical variances, and do you think about all that acid in the stomach, if it's, has an opportunity to bulge through the opening of the diaphragm, we are just, there's just a further complication of pressure and backflow of acid. And our esophagus, has its own protective mechanisms as well, much like our stomach. But when we are experiencing that backflow, it's difficult to combat. The esophagus has a different tissue composition than our stomach. Our gastric cells are well equipped to live in that high acidic environment, but our esophagus is not. So we're going to start to see that breakdown of that mucosal defense, and also an alteration in esophageal motility. So considering esophageal peristalsis, and if there is a delayed gastric emptying as well, we're just creating the perfect storm here for acidic content to be in the esophagus, breaking down the tissue, a mismatch in pressures, and ultimately, if we combine the dysfunction of all four of these mechanisms, then we have GERD. Risk factors for a decreased LES tone include alcohol, smoking, obesity, caffeine, pregnancy, medications. So a few of those medications include calcium channel blockers, beta-adrenergic blockers, anticholinergic medications, just given their anticholinergic effects. You think, very dry. We are slowing the, gut perfusion. Things are dry. They're slow. They're dry. We are blocking that parasympathetic activity. Opioids, benzodiazepines, nitroglycerins are all medications that can contribute to a weakening or a decreased LES tone. Diet is a big one. Certain foods can place a higher risk of GERD. Spicy foods, fat fried foods. And think of anything with an acidic base: tomatoes, tomato sauces, citruses, even peppermint, spearmint. These can all can exacerbate symptoms of reflux. And actually, there was an interesting study that looked at the relationship between fiber and symptoms of GERD. And actually, a high fiber diet will decrease the risk of GERD because we're seeing an increased gut motility and increased gastric emptying. So inversely, a low fiber diet is a risk factor because there's decreased gut motility, decreased gastric emptying. And even as we start digesting, it doesn't have that same bulk and weight to it. So a low fiber diet causes all sorts of GI complications. Obesity and pregnancy, it's just a matter of increased pressure, extra weight, abdominal pressure that is pushing everything up. So we're further promoting the travel and velocity of that trajectory, of that acid where it shouldn't be. So we've already touched on a few of these symptoms, the classic symptoms of GERD being heartburn and regurgitation. A few of the atypical symptoms, someone may present with chest pain, or it might manifest as asthma, laryngitis, dental erosions. Asthma is very interesting because you just think, well, what does respiratory have to do with GI? But we're thinking about the irritation of the esophagus, and those irritants are a trigger, for some airway spasms, and it can even affect our speech. Altered disorder of the voice or an abnormal voice, painful swallowing, difficulty swallowing, globus sensation. So all that irritation in the esophagus has created this feeling that there's a lump or something in the throat that isn't there. And all these symptoms they really just tie back to that irritation and damage from the gastric acid. On a physical exam, really the information we're going to gather will really be from the history of present illness. The physical exam is usually pretty unremarkable. The only physical sign that the provider may see is a positive occult blood upon rectal examination, and that's just from the microhemorrhages in the esophagus. But otherwise, in an otherwise healthy individual, the exam is within normal limits. There's nothing too exciting on physical exam. As the provider, a few differential diagnoses to consider with GERD are if someone is presenting with chest pain, we want to do a cardiac workup to rule out any disease or condition of cardiac origin. Something that may give us a hint is if they present with pain that's associated with exercise and then relieved by rest and nitrates. That's pretty classic cardiac. But it does get complicated because someone with, say, angina might be treated with some of those medications that also decrease the esophageal sphincter pressure, so calcium channel blockers, beta-adrenergic blockers, nitrates. So even as we're getting that, we're getting the effect that we want to manage things on a cardiac level with that relaxation and dilation. We are also creating another problem as well with the esophageal reflux. And we should also consider gallbladder disease, with the epigastric pain, nausea, but by gathering a complete history, we may get some clues as to whether this is a cholelithiasis, cholecystitis, or GERD. There are always labs that we can rule out any, pancreatic enzymes, liver enzymes, if there's anything fishy going on. Peptic ulcer disease can mirror GERD as well, but we want to pay attention to that relationship with food. Is it worse soon after eating? Is it relieved with eating? And just paying close attention to those details. So labs and diagnostics, we talked about the physical exam is pretty unremarkable. The labs in relation to GERD, we might draw labs to rule out some other underlying causes of the symptoms, but usually the diagnosis of GERD is made by history, and then from there we will start the empiric treatment with a proton pump inhibitor or a PPI, and if the patient is not responding to that therapy, then we would proceed to an upper endoscopy. We are concerned about a complication of GERD or an advancement of GERD being Barrett's esophagus, just with that chronic exposure to acid, and then the cells begin to change in response to that new environment. And Barrett's esophagus is a precursor to esophageal cancer. So as far as diagnostics, once we're at a point where the EGD is appropriate, with direct visualization of the esophagus, stomach, and small intestine, we can start to take some biopsies for histology. Our plan of care is going to be a combination of non-pharmacological and pharmacological interventions. So starting with non-pharmacological, we can consider weight loss, small frequent meals, trying to avoid those foods that can exacerbate symptoms of GERD, that reduce that LES pressure. So avoiding those tomato-based, citrus, very acidic foods, coffee, smoking cessation, diet and exercise. That's going to help with the weight management. Stress plays a big part in GERD as well. Just from a holistic approach, there are things that we can be doing with medication. So changing your eating habits, not eating too close to bed, not eating 4 hours before bedtime, elevating the head of the bed by just a few inches can make all the difference in the world. Trying to prevent the backflow of acid while we're sleeping. But usually we are integrating medication as well into our plan of care. Pharmacological interventions. So with antacids and PPIs, these are available over the counter. So a lot of people self-medicate. They've been managing these conditions for a long time. It just goes to show you how prevalent the disease is. But we do want to closely manage their dose. We'll usually start with that 8-week trial, the empiric PPIs, which will take 30 to 60 minutes before a meal, like putting on sunscreen before you go to the beach. And this disease is a lifelong condition, so it's going to require regular follow-up. We don't want this advancing to a Barrett's esophagus or worse. So paying close attention to see if the patient does respond to that 8-week trial. If not, we can advance that dose to a twice daily dosing, again, taking it 30 to 60 minutes before a meal. And if we combine our non-pharmacologic, weight loss, diet, exercise, some diet modifications, stress reduction, and medication, can be pretty successful, and continue to work with a gastroenterologist.